So thank you very much. I think all the speakers did a wonderful job. I'm sort of a little bit distracted because I'm trying to look at the Q&A box here and trying to address some of the questions. I've written down some of them here, just trying to cluster them. The first thing I'll say is that there's a number of questions in there that are clearly coming from individual patients who are asking questions about their specific management and what they should be doing and what they should be telling their doctors. We have to remember this webinar is about education, and it's about sort of global, sort of sharing of information between different specialists and different jurisdictions. So, each of the speakers spoke very eloquently about their experience and how they do it. But again, you have to keep that in mind, that we're not doing this to treat one specific individual. And there's maybe a number of circumstances in your care that need to be considered. Having said that, part of the objective today is to raise the awareness and bring attention to all of this topic. And maybe in your jurisdiction, I think one of the questions was, do you know anybody in the UK or specifically in Scotland that can help me? You have to kind of look around, and identifying individuals who have expertise in this can sometimes be very challenging. We can try to address some of these questions, but we're not going to be treating any individual patient here. So having said that, there's some questions with regards to imaging, and I'll throw this out to the speakers. There's some questions with regards to comparing nuclear studies and myelograms. When do you sort of do myelograms, and when, nuclear studies is a good substitute. I heard some comments about not doing that many myelograms and just really focusing on MRs and the different sequences. So maybe some thoughts from the speakers on, how do you see, the use of imaging? Because some of the other questions were, are we at a stage now where we can stop doing such invasive imaging, such as myelograms? Because myelograms are very invasive. We're putting a needle in, we're flipping the patient practically upside down and flipping them on their sides and doing it multiple times to really identify that leak. So let me stop there. And the topic is imaging, nuclear studies, myelograms, MR sequences. What are your thoughts?
Well, I think, particularly in people who have a post-dural puncture headache, you really should try to avoid another lumbar puncture, right? And I think that's one of the reasons that sometimes surgery is not successful, because you might know exactly where the lumbar puncture was done, but it's possible that they're now actually leaking from where the CT myelogram was done, or, oftentimes they'll have, 3, 4, 5 CT myelograms. So we really try to go away from invasive imaging. So we rely on MR myelography. We really haven't done radionuclide cisternograms for at least a decade, because I think it's not that helpful. It's really almost useless for identifying the exact site of the leak. There might be something to be said for, in a really difficult situation, that the cisternogram might be able to sway you. Oh, does this patient really have leak symptoms or not? Or are there symptoms from something else? If there's poor progression of the radionuclide over the hemispheres. It's just that I think, like I showed you that paper in Brain, more often than not, greater than 2/3 of the time, you will get a leak from the lumbar puncture. So when you look at large series of people who have cisternograms done, and they'll say, oh, look, we found a leak, you'd see that 80% of those leaks are in the lumbar spine. And I think those are just leaks that are caused by the spinal needle that's used for the cisternogram. But, other people do it differently. And I know there are some places in the US who very much rely on cisternography.
Walter, I agree. So can you hear me? Or yeah. So I think additional invasive diagnostic workup is not necessary in those patients who do not have any epidural CSF collection. And So in most cases, without any epidural CSF collection, you will do a myelography or nuclear cystoscopy. You will have an additional puncture, and you cannot be sure if it is iatrogenic, the CSF leak, or if it is an original CSF leak. So therefore, I really only use a myelography if there is a CSF collection epidural, and so I want to see if I can define the exact site of CSF leak. If not, so I only use MRI, try to see any dural defect, such as bleb or some neozac, something like this, and then I go for surgery.
Yeah, as the other neurosurgeon on this webinar, I don't feel comfortable doing exploratory surgery, and I was interested in your comment with regards to, half of the time it doesn't seem to make a difference when you go and have a look. So I kind of tend to push for the myelogram, and really, and I work with Richard Farb, so I go back to Richard and say, find me the leak. Without a very specific leak, I'm not. Now, this is with the spontaneous ones, the ones with a history of pseudomeningocele. Maybe the story there is obviously a little bit different, and the MR images and the different sequences can typically point to where the defect is. I like knowing whether I'm going to have to sort of open the dura and go through and repair the anterior part of the dura, or is it all sort of posterior? Even laterality can make a difference. So for me, that's kind of where the bar is. I need to identify a leak, and really, unfortunately, the technique for that is the myelogram. That's kind of where it's at. Maybe moving on, there was a lot of questions about the epidural blood patches, and some of the questions were in respect to symptoms. So after the blood patches, some patients experience worsening of symptoms, or more back pain, radicular pains. And maybe this is one for Farnaz, your experience in dealing with patients who've had this, and maybe Ian can chime in as well, because, the two people who do blood patches. But what has been your experience with patients and their symptoms with EBP? And the other part of this that I'll throw in is with rebound headaches and some of the symptoms surrounding that.
Yeah, for sure. So in regards to blood patches, of course, done for both spontaneous as well as the post-dural puncture headaches, we do find that there is a good percentage of patients that do have some back pain afterwards. Less likely radicular, I would say, in my experience. Often it's more musculoskeletal, where they just have some sort of ache and tension that's there for a number of days. But most of the time it does go away. I don't find that I've had many cases where it's been long lasting, fortunately. And in the cases where they might be a little bit of radicular pain, obviously we collaborate with our anesthesia colleagues and have them assess to make sure that there's been no concern. That way we do examine them. They often will do a neurological exam if they see the patient or myself on call, if they do come back within the sort of first few days after a blood patch with issues. And in some cases, we have had to use some pain medications or analgesics like NSAIDs, or, in rare cases, something like gabapentin, which is a neuropathic pain medication. But in most cases, fortunately, there hasn't been any major complications that I've been aware of at our site, at least. And Ian definitely can speak to this much more, having done a lot of them. In regards to rebound intracranial hypertension or high pressure headache, this is relatively common, I would say, actually, for any type of procedure that closes a leak, whether that be blood patches, fibrin glue, or surgical procedures. So I think it really, you have to take the time to take a good history from the patient and determine that that's what's going on, first of all. You really have to look for those features that are often the opposite of the orthostatic headache, right? So they often feel worse when they're laying down. It's often a headache that's first thing in the morning. And they can have other associated symptoms like visual symptoms, transient vision loss, or double vision, diplopia, or pulsatile tinnitus. And often we will, if it's, more severe or more rapid progression of that, sometimes we will image them to ensure that we're not dealing with a complication like a venous thrombosis. So they may get some CT or MR imaging. But otherwise, we do treat them similar to, any type of high pressure headache using Diamox or acetazolamide, but with careful monitoring and follow-up, because a lot of them will improve over days or weeks. So we do have to kind of be careful that we're not also overdoing it with the Diamox. So just gradual start, gradual escalation as needed, and then gradual tapering with close follow-up. So that would be our experience here in Calgary. Ian, I don't know if you probably have more to add with the blood patch, given your experience.
I would say with the blood patch, back pain after a blood patch, very common for the first week, even really the first couple of weeks, then seeming to improve in the vast majority. I think if I had to guess, I would say probably there's something like a 1% rate of people reliably saying, yeah, I had new or substantially worsened back pain after epidural patching that seems sustained and clinically significant. Clearly can happen, clearly happens at a low rate, whereas early pain after the patch is very common. And in fact, I would say radicular pain after the patch is very common. So it's clear that blood on nerve roots is irritating, and people will get a sense very commonly of discomfort going down their legs. If I'm doing a high volume lumbar patch and they say I'm getting, some pressure down my leg, I'll typically, give them some time and ask them if it's feeling better, and then work in a little more and work in a little more blood. So the simple occurrence of some radicular symptoms when I'm in the lumbar spine doesn't usually stop me from necessarily giving them more volume. Very different when I'm in the thoracic or cervical spine, where I'm not just worried about putting a little pressure or irritation on the nerve roots, but the cord itself, which we don't want to put any pressure on. I've had one patient that comes to mind who had very clearly worsened long-term radicular pain following a patch. And the same person I saw in follow-up recently, totally fixed from her leak, totally fixed from her headaches, which had been chronic. And I asked her, did she feel, all things being equal, would she rather have not had the patch and not been treated? And she happened to feel that she was better off for it, that she could manage the radicular pain with the combination of a TCA and a gabapentinoid. But I mean, when you have one patient like that, it sure makes you think very seriously about what you're doing and why you're doing. With regard to the rebound high pressure, I think it's clearly a problem. Dr. Shivink has published stuff he can talk about in terms of preoperative or pre-patching imaging, suggesting who's at higher and who's at lower likelihood in terms of venous sinus dimension. And we continue primarily to manage those again with Diamox, topiramate, potassium citrate to prevent kidney stones. And recently have had 2 patients with long-term rebound who appeared to be feeling better with a GLP-1 agonist, with this class of medications used in diabetes that appears to show good effects in reducing intrathecal pressure in animals. So I'm now aware of 2 patients who have had long-term rebound that seem to have benefited from that. We'll see. They're still early on in it, just months rather than years. So we'll see if that winds up being helpful. Wouter, do you want to chime in on rebound?
Well, a couple of things. We used to think if a person got a rebound headache after a treatment, we thought, oh, that's a really good sign that proves that you had a leak. That, of course, is not the case, right? So particularly in post-dural puncture headache patients, if imaging is all normal and you do a blood patch, a lot of patients will get high pressure headaches. And I think the reason for that is that either there is no more leak or the leak is just minimal, right? If you or I would get a blood patch, especially if it's done high volume, we would definitely get a high pressure headache lasting for a few days. Diamox is a great medication for high CSF pressure headaches, but it has a lot of side effects. So we usually start with dandelion tea. 2 cups a day is all you need. Apparently, it doesn't taste that good, so you also can get capsules.
Yeah, this really emphasizes the fact that the CSF dynamics, the production, the absorption, and you throw in a leak and you throw in some changes between the cranial and the spinal compartments. We have to pay particular attention and realize that this is a very dynamic process, and there's physiological factors that weigh in. There's a number of other factors that we have to put into the equation. One of the comments in the Q&A box was with regards to the size of the leak or the size of the dural tear. And I have to remind the listeners that for the most part, we don't really, and I love the pictures, that were shown in the presentations, with the dural tears, and how really have a way, unless we go and do surgery, to go and see those tears and see how big they are. But in my experience, the size of the dural breach does not always correlate with the symptoms. And again, this feeds into the conversation about the idea that the amount of CSF flow that works through and how your body compensates for that. I think that plays a bigger role in some of your symptoms. Question regarding arachnoiditis, and this I'll open up to other people. There's a concern that the coexistence of arachnoiditis and CSF leak, and how do you tell the difference, etc. This individual had a number of questions that kept coming up with regards to arachnoiditis. My experience with arachnoiditis in these cases, and again, arachnoiditis is a very important entity, but as a surgeon, it's not something that I can do much about with regards to treatment. Obviously, when we do intradural work, we want to minimize the chance of development of arachnoiditis. So cleaning out the intradural compartment and making sure there's no blood products or anything that'll create an inflammatory process. Any other comments from the panelists with regards to arachnoiditis and what they've seen in managing patients?
I've had a few cases now where patients who've had repeated blood patches or procedures of the spine unfortunately have developed it, and it can be very debilitating, unfortunately. Like you said, there is really not kind of an option that works for everyone, but what we found is that high-dose steroids, such as IV solumadrol or methylprednisolone, usually over the course of a few days, along with neuropathic pain medications like gabapentin or pregabalin, can be helpful, but that these patients can have long-term effects. Unfortunately, I have a young patient who's developed this, and even at the best, she's got pain on a daily basis that kind of interferes with her day-to-day activities. And then for whatever reason, she gets flares of pain from time to time, and we do have to unfortunately go to the high-dose steroids to try and settle things down. And sometimes, imaging can be helpful for that, because there are features on MRI that can be helpful to help distinguish it from other factors. But in her case, actually, the imaging wasn't fully supportive either of the diagnosis, but clinically she does fit well with that diagnosis, and has significant radicular symptoms and back pain and paresthesia. So it can be quite debilitating.
The only thing I would add is we at one point made a video posted by Stanford to YouTube on the treatment of nerve pain, which talks, I think, in a lot of detail for lay people about what we understand about nerve pain and medical treatment options. And arachnoiditis would be kind of a classic case of nerve pain. And so for those interested in learning more about the medical options that might be overlooked by a primary care doctor, I would direct their attention to go perhaps look at that video.
Thank you. No, that's very helpful. It's a challenge. It's a challenge as medical practitioners. One of the comments in here that was made was with regards to how can we raise awareness to obstetricians and other individuals who perform these epidural procedures, to raise awareness that this actually happens more often than they realize it. The other sort of thought was with regards to our pain specialists. As we see this explosion of pain clinics, well, certainly in Canada, this is something that's definitely on the rise. And their threshold for doing injections seems to be getting lower. We're going to see possibly even more. And that's why some of the literature that Farnas presented, was quite uncertain. We don't know what the incidence is, because I think it's an evolving field and we need more information. But certainly making sure that our pain specialist colleagues are aware of this, and not have them kind of go off into their area and not be cognizant that this is a possible complication that has quite serious repercussions. The other question that was put out here was with regards to an association between CSF leaks, either post-lumbar puncture or otherwise, and connective tissue disorders. And the one that often comes up here is Ehlers-Danlos syndrome. Any thoughts from the panelists with regards to those two entities?
So in my patient, I really rarely see a proven Ehlers-Danlos or Marfan syndrome. It is so some patients are hypermobile. They can they have some tissue hypermobility, but so it is really rare condition that the Ehlers-Danlos or Marfan syndrome is really diagnosed, in my point of view. But there are a lot of case reports mentions this. Yeah.
There was a Dutch neurosurgeon who published about a decade ago that in people with spontaneous leaks, even if they didn't have Marfan or Ehlers-Danlos, they were much more likely to show on physical exam stigmata of benign joint hypermobility and other stigmata of connective tissue. He's here on the panel somewhere. But to my knowledge, nobody has done that same thing with persistent post-dural puncture headaches. And the same methodology could be used to say, if you looked at people with persistent post-dural puncture headaches and compared them either to healthy controls or controls who had a dural puncture that resolved, are you more likely to find things like joint hypermobility? I don't know that it would really change that much. I mean, would women with known joint hypermobility not get epidurals when they had their childbirth? My experience is people are very resistant before they have a problem to doing concrete things in anticipation that they might have that problem. I think that we are not built well for prophylactic, as health systems wise, we often look for prophylactic things because they're cost effective. Individual wise, we tend to avoid things that that might uncertainly have a prophylactic benefit from a problem we don't believe we will ever have. But with that, I'll let Wouter speak to that.
Well, I think you're definitely right about making that point about prophylactic healthcare, not just in this situation, of course. But I think, I do think patients with Ehlers-Danlos syndrome, and, I'm not talking about the classical syndrome where you have a type 5 collagen mutation. I'm more talking about the much more common, just patients with a high Beighton score with joint hypermobility, for which there's no genetic mutation that's ever been identified. And what, Dr. Carroll mentioned, we did write about that. We had a geneticist from Israel who looked at a lot of patients that we saw during his fellowship here at Cedars. And it did seem like that was very common, but we never had a control group, right? And then I think there was a study in cephalalgia from Taiwan where they did have a control group, and things like joint hypermobility there was absolutely no difference between patients with spontaneous leaks and patients with headaches from other sources. The only difference is that I think it's called dolichostenomelia or something, where you have really long arms compared to your height. That was the only significant difference in patients with spontaneous leaks versus the control group. And I think, you know, a lot of joint hypermobility problems, it's such a heterogeneous group of patients, it'll take some work trying to figure that all out. You know, unfortunately, at least as of now, there's not a reliable type of animal model to look at, you know, the dura, integrity of the dura, things like that. And certainly, like Dr. Ulrich said, you know, Marfan syndrome, we often talk about that, but it's, you know, it's like less than 1% of patients we see with spontaneous leaks.
Can I ask a question?
Please.
This is a question I've posed to Dr. Shivink just recently, but I'd be interested to hear Dr. Ulrich and Dr. Massicot's thoughts. When I see the pictures of these dural defects that are well epithelialized after a microspur or something like that, and we hear about how sometimes with these punctures, the results, while very meaningful, I think, you know, you take 50% of people who are living with a chronic leak and you fix that 50%, like that's well worth doing. But is it possible, and to what extent do you think it might be contributing, the epithelialized edges of these defects? Is there a role for roughing up the edges, maybe scraping the epithelium off the edges before sewing the defect closed to maybe enhance? I see. What are your thoughts about that? You know,
as delicate as I think I am during surgery, when you go and put a stitch through it and you close it up, I don't think I need to rough up the edges, because there's going to be scar tissue that's going to happen around that area as well. So even, you know, I just did a case last Wednesday, and you know, Richard had told me, okay, you're going to find a leak, it's going to be here, and I found it. And while I'm repairing this leak, I sort of always scan up and scan down, just, you know, having a look around, making sure the intradural compartment is nice and clean. And I found another spot. And like you say, it was well, I mean, this gentleman had symptoms for, if I remember correctly, at least 3 years. So chances are the edges of that are not going to be rough. It's not going to be something that just happened a few weeks or months ago. And so the epithelialized sort of edges and the chronicity behind it certainly was suggestive. But I think that, you know, we go in there and we kind of put the stitch in and we close it and we think it's a nice watertight seal, but really we're also relying on some degree to some of the scar tissue from the surgical intervention that we do. So going in and roughing up the edges, I don't think is really necessary. Christian, I mean, what are your thoughts?
So yes, so normally in some cases the different layers, I mean, dura, arachnoid, really stick together. I try to separate the layers so to get the anatomically correct layers together. And so I do not cut any edges from the dura or to have new cells growing in. So depending also on the size of the leak. So in for example, the classical post-functional leak, this is a very small leak, and in some cases dura is very thin. So I try even to avoid to use stitches because I am afraid of making a new CSF leak. So in those cases, I use a patch more likely. I prefer a patch, and so patching is also some kind of risky because your patch can loose, and therefore I use the mentioned 360-degree dura wrap. So you can finally fix all around the dura the situation and it cannot dislocate anymore. So separating the anatomically correct layers, that's in my opinion, very important, using not in all cases suture and the dura wrap. No.
Great. So I'm sensitive of time. It's already 2 o'clock here, Eastern Standard Time. So we've been at this for a full 2 hours. I think one of the last questions I'll ask is if the panelists are open to having patients contact them directly to, ask about specific care, pathways, etc. I can tell you that in my case, we are in the process of developing a formal intake process for people with CSF leak. Right now, it's just, a question of sending an email and we redirect it to our local neurologist, etc. But I think, if you're interested in an opinion from Dr. Carroll, Dr. Shevink, Dr. Ulrich as well, but I think you're a little bit out of most people's jurisdiction. But if you guys are interested in taking on questions, we can certainly work through the Spinal CSF Leak of Canada. You can send your inquiries there. For those of you who I didn't get to their questions, I apologize. We broke the 100 mark questions on the side, so I tried my best to answer as many of them. If you don't have answers that you're happy with, then certainly forward them on to the organization and we can try to address them post-webinar. On that note, I'd like to thank everyone for their participation. I think this was a wonderful activity, which hopefully will elevate the overall knowledge about this entity and hopefully improve the care of all of our collective patients. Thank you.